We're at Jupiter Medical Center in Jupiter, Florida today. We're in the operating room. We're walking into operating room 4. It's one of our operating rooms that has the DaVinci Xi system that we use for robotic surgery. And here we are sitting down at the console. When we think of DaVinci, we think of an artist, an inventor, an architect. We don't really think of the person that helped develop the first robot, the mechanical knight. He was given special permission at the time to dissect human cadavers. He wanted to see how the human body worked. And he looked at the different muscles and the tendons and the bones and the pulley systems within the human body. And from this, he developed the mechanical knight. It wasn't a regular knight that we would think of. It was a very large knight. And the knight was initially made for defense or for war. And it never reached that point, though, because he used it more for entertainment. And it was able to move its arms and to walk and to do different things. This was left undiscovered until his notebooks were found in 1950. From the notebooks of Da Vinci, various models were made, and they're in museums all over Europe. They are working models from his mechanical knight that he developed 5 centuries ago. And now, fast forward to today, the intuitive surgical system was developed from the mechanical Da Vinci knight. The intuitive story starts in 1995 when a group of highly intelligent people got together and they developed the intuitive robot. It was modeled after the DaVinci robot. What they did is they had a prototype, and this is a picture of the prototype, the first surgeon console in 1996, and it's evolved a lot since then. Fast forward to 2000, the year that DaVinci launched the surgical system, and they got FDA approval for the robotic surgical system. And this is a picture of one of the early intuitive surgical systems that we see. This is one of the earliest models. Jupiter Medical Center was one of the first hospitals in the nation to have an advanced Xi system installed in its operating room. We were able to do this because of Dr. K. Adam Lee, a chest surgeon and robotic visionary who brought the robot program to our hospital. He was able to do this in concert with Jupiter Medical Center Foundation and our donors to be able to get this type of platform. With Dr. Lee's efforts and with the efforts of the Jupiter Medical Center Foundation, the Frank and Mary D. Walsh Robotic Surgery Program were created. With the introduction of the Xi system, this established Jupiter Medical Center as one of the first facilities in the world to possess this type of technology. This is a picture of Dr. Lee with one of the robotic trainers. Not only did he start the program, but he also created a program to help teach other surgeons across the country robotics. He had his own team, and he trained them to develop the capabilities at Jupiter to perform a lot of advanced chest surgery. Joining Dr. Lee is Dr. Donna Pinelli, a gynecological oncologist who became head of our robotic program. She, along with her team, achieved recognition doing advanced GYN oncologic surgery with the robot. Here she is receiving special recognition for doing over 2,000 robotic surgical cases with her team. This is no small feat. It's pretty amazing. And this is a year or so ago, and since that time she's done a lot more robotic surgeries. As I said before, Jupiter Medical Center has 3 Xi systems. Most hospitals just have 1. And then there are a lot of hospitals that have no robotic systems at all. Here at Jupiter, we have 170 credentialed surgeons, but only 33 of us are credentialed in robotic surgery. The credentialing process begins with understanding the 3 components of the robot. There's the brains, the console, and then the working portion of the robot. This is done by taking training modules on a computer and then taking tests after each module. After this is done, then there's training exercises where specific scores are needed to progress to the next level. Various training exercises are used. This is an abdominal trainer. We do different exercises like moving these little rings, and also we can move these rings across a wire in different directions. This simulates different things that we would do in actual surgery. We also practice sewing, and not only do we sew, but we can tie knots intracorporally this way. Because of the advanced technology of the robot, this is a lot easier and so much better than doing it laparoscopically. We have a lot more control. You can see us pulling the thread through here. And if you can see, there's a clutch on it too, so that your arms don't become outstretched, reaching for different portions within the body cavity. The foot pedals allow us to control the camera, cauterization, and various instrumentation. Also, we wear special socks when we do robotic surgery. It's all about the socks. That way you can feel the pedals with your feet. You can't really wear shoes because you won't be able to have the sensitivity with the instrumentation with using the pedals, because you can't really feel them. Also, there's a side pedal that lets you switch arms from arm 3 to arm 4, or you can change the different arm configuration on the control panel, so that you can use 4 arms, and you can basically coordinate it back and forth however you need to hold something, and then to keep that arm still, and then to switch to a different arm. When you look through the robot console, the view is 3D. The graphics are incredible. They're so clear. It's a whole different experience than looking even through laparoscopic cameras. The robotic operating rooms here at Jupiter have large monitors, so everybody in the room can see what's going on with the procedure. The robotic brain has a screen that you can touch and you can draw on, that can be seen through the console by the surgeon. That way you could point to something and they could better understand what you're talking about. This is also helpful for teaching. These are like things that were not available before, but thanks to new technology, they're at cutting edge. Finally, an animated model with the actual XI system is used. After all this is done, then the first case is done on humans. With these cases, it is necessary to have a proctor, an experienced robotic surgeon with you for the first 6 cases. After that's done, then finally you're credentialed after the surgeon signs off on your competency. I started laparoscopic surgery many years ago. I didn't think it was really going to go anywhere, but I felt I needed to keep up with the technology. And then when robotic surgery came along, I felt the same way, that I just needed to learn it, but I didn't really think I would be using it. And I ended up going away to the robot course. I went through the training modules, I did the lab, and then I did the 6 proctored cases and finally got my privileges. And it was something that I thought it was just good to have, but I didn't really think I would be doing much with robotic surgery, because in the beginning it took 2 or 3 times the amount of time as laparoscopic surgery. I could do a laparoscopic hernia a lot quicker. But then I started noticing the outcome on my patients. They returned to work faster, they returned to golf quicker, they had less pain, and at that point I knew that I couldn't look back and I needed to continue with this type of procedure. So the robot really makes sense for inguinal hernias for me because of the outcome. 27% of men have inguinal hernias. 3% of women have inguinal hernias. There's 20 million procedures done for groin hernias worldwide. 700,000 are done in this country alone. This is the most common abdominal surgery. What is a hernia? It's a condition that's plagued man since ancient times. In fact, the word hernia comes from the Greek word hernios, meaning bud or offshoot. Simply put, it's a hole in the abdominal wall muscles where viscous or fat or something protrudes. The problem with hernias is during a course of a lifetime, it will enlarge, it will get larger, and it will eventually impair the person's ability to perform daily activities. Why repair inguinal hernias? Well, there's concerns over incarceration where you cannot reduce the bowel, as in this picture. And of course, this can progress to strangulation, where you have a portion of bowel that dies. It can cause an obstruction, or you can have some other problems and issues that can lead to sepsis, shock, and even death. And so this needs to be treated in a timely manner. Asymptomatic hernias can be watched. You can use non-operative management and just keep an eye on that person. Once, though, they start having symptoms, it's important to have surgical intervention so they do not get incarcerated or strangulated. And symptoms are pain or they can't reduce it. This is important. There is a study in Annals that does show early repair before symptoms. There's no increase in morbidity, and it may prevent future problems that the person will definitely have. There's a increasing percentage of incarceration as time goes on having a hernia that's untreated. Eduardo Bassini in 1984 became the first surgeon to successfully develop a procedure for inguinal hernia repair. He was able to reconstruct the inguinal canal and restore the person's anatomy. This is an anatomical repair that he used with the person's own muscles. Unfortunately, it's not really used anymore because of the high recurrence rate. There are many options to have your hernia repaired. You can do it open, laparoscopic, or robotic. The best option, I think, is the option that your surgeon's the most comfortable with. The first robotic inguinal hernia was done by a urologist in 2007. He ended up doing a series of these with inguinal hernia repairs and radical prostatectomies and did an article on this. This was quickly picked up by general surgeons. And why now are we using a robot for inguinal hernia repairs? Well, I think if you start looking at the robot itself, it'll give us the answer. The instruments of the robot have a wrist, and they're gentler and gentler handling of tissue. With laparoscopic instruments, if you take a look at them, they are straight sticks, and you need more manipulation and maybe tension and pressure on the tissues with laparoscopic type instrumentation than you do with a robotic instrument. Looking at current literature, there's a real shift now towards inguinal hernia repair from the robot, and data from the Michigan Surgical Quality Collaborative from 0.7 to 28.8% over a 6-year period is pretty impressive. Now more and more inguinal hernias are done robotically. The recurrence rates are similar. It's just a choice for the surgeon. I think if you really take a look at the robotic approach, there's a lot of advantages. You can get a closer and more detailed look at the anatomy because of the graphics within the robotic console. It's 3D and the pictures are much better. And looking at the anatomy, you can avoid certain pitfalls. One of the things that's extremely dangerous in doing inguinal hernia repairs is, of course, the triangle of doom and the triangle or trapezoid of disaster. The triangle of doom is where major arterial and venous vessels are. In the triangle of pain or the trapezoid of disaster, the genitofemoral nerve and lateral cutaneous nerve pass through this area, and they can cause chronic pain if they're injured. The other advantage that we have with the robotic view is that you're able to see if there's a femoral hernia as well as inguinal hernias, and you can repair them all at the same time. With a robotic approach, as with a laparoscopic approach, you can fix both hernias if you have an inguinal hernia or if you have femoral or obturator hernias at the same time through the same approach. Also, you can fix prior recurrences from open repairs. We usually see less pain and faster recoveries. There's better visualization. And of course, like anything, there are contraindications. It's not the be-all or end-all. A lot of the contraindications are the same contraindications that you'd have to general anesthesia or to laparoscopic surgery. And here's a few. Basically cirrhosis, somebody has bad cardiac disease, or it's a super large hernia, and even those now are being done on the robot. Mesh or no mesh? Well, for us as surgeons, it's pretty simple. Without mesh, the recurrence rates are really high. With mesh, the recurrence rates are a lot lower. You have a 50 to 75% reduction in recurrence rates if you use mesh. I usually start off my conversation with my patients that it's better to use mesh, and the mesh that we're going to be using is not the mesh that everybody's getting sued over. The mesh affords us a tension-free repair, so you have less pain. Once you decide to use mesh, the next decision is how are you going to secure the mesh. Well, there's different ways. You can use sutures, tacks, staples. I use a self-sticking mesh. Studies have shown that there's no difference in infection or pain or recurrence rates with self-sticking mesh. Here's a picture of the mesh that I use. It's got reabsorbable polylactic acid gripping system. It's got these little fingers that grip into the structures and then dissolve and get absorbed so that the mesh has its own strength. If you look at this study at day 5, the microgrip technology is comparable in strength to hernia stapling. And then in 2 months down the line after the repair, it's better than stapling. And then looking at this study using analgesia and pain control, you can see that there's reduced doses of pain medications necessary using self-sticking mesh. There's less pain, and it does make a lot of sense. It's less painful just having something laid onto a defect versus stapled or sutured in. Looking at morbidity with open laparoscopic or robotic inguinal hernia, you can see that the recurrence rates, chronic pain, and complications look pretty similar. This is from meta-analysis type studies. But like everything, it has its risks. And if you take a look at the risks of robotic surgery, they're almost the same as with open surgery. For me, the major risk factors of the robotic surgery are the tactile feedback. The other risk factors are similar or maybe a little bit more involved with the robot versus open surgery and laparoscopic, but the feedback, you have to look for visual cues on the screen. The instrumentation does have built-in safety factors with grip strength, and the learning curve is pretty steep. You have to do a large number of cases before you feel really comfortable with this platform. Having said that, I think the outcomes are worth it. The people that I see have less pain, they get a quicker recovery. It just seems like it's a better operation. I've never had patients go out to dinner the same night that they had surgery. The thing that was a turning point for me was I had a 94-year-old man that came to me and insisted that he have this done robotically. I was really hesitant. He had a really large hernia, but I listened to him and we did it on the robot. And within 2 days, he was out playing golf, carrying his own golf clubs. And after that, I never looked back. And I really believe that this is the best way to repair an inguinal hernia. I know I'm not alone in feeling this way. The Annals of Surgery, the December 2021 issue, came out with a really big study. It was a systemic review and updated network meta-analysis of 27 controlled studies involving 5,721 patients. And it showed open inguinal hernia repairs may not be the best for our patients. They used the Lichstein tension-free repair, which is the gold standard now for open repairs. It has a low recurrence and complication rate, about 1.9%. With the meta-analysis review, they found the hernia recurrence was similar for the Lichstein and for the minimally invasive surgical repairs. The clinical differences showed minimally invasive repairs or robotic repairs appear associated with a reduced risk post-op hematoma, wound infection, early post-op pain, and also earlier return to work. This is the newest generation of mechanical knife, the DaVinci SP system. It can fit through one single cannula, a 2.5 centimeter incision, and all 4 instruments that are all wristed can go through this. This is the first time that the endoscope is wristed as well. It's got the capability of 360-degree access when it goes into the body. This is something that's being prepared for the next generation of surgery, especially for natural orifice surgery. It can go through transoral, transrectal, and transvaginal procedures. This is a picture of the setup. It's the same, similar for the XI, except for the single cannula and the wristed instruments. You have the brain, the console, and the working portion of the robot. Fast forward now from the year 1400s with DaVinci's notebooks and DaVinci's thinking, and now I believe that this is the best way to have your inguinal hernia repaired using this technology for the best outcomes. Any questions? I'm happy to take any robotic questions, and if you want references, please let me know. I'm happy to send them to you.
Thanks for coming. I really appreciate your time, and I hope I made a difference about how you think about inguinal hernias and robots. I really believe that this is really the best way to have something like this done, minimally invasive through 8mm incisions, and you'll get, I think, the most comfortable type of repair, and I think you get the best outcome using the robot.